Here is part of chromosome 11 in an adult, showing a normal active beta-globin gene and a normal but inactive gamma gene. The product is the beta-A globin chain, which ultimately assembles into hemoglobin A tetramer, 2 beta and 2 alpha, here shown in red, indicating that it's fully oxygenated. When it gives up oxygen, here shown as blue, it assumes the deoxyconformation, a reaction that goes back and forth as it shuttles from tissues to lungs. Here are the genes of an adult with a mutation in the first coding region of the beta gene. It produces an abnormal beta-globin chain with a valine substituted for glutamic acid. This is sickle beta-globin, beta-S. 2 beta-S combine with 2 alphas to produce sickle hemoglobin, shown here in its fully oxygenated red configuration. When it gives up oxygen to tissues and assumes the deoxyconformation, it differs from hemoglobin A in that the substituted hydrophobic valine becomes exposed on the outside water-facing surface of the tetramer. Most of the time this doesn't cause any problem, as it too shuttles to the lung and gets reoxygenated. The problem occurs if, when, and where the cell finds itself dwelling in a deoxy environment for a significant amount of time, especially if the pH and temperature are low and the concentration of sickle hemoglobin is high. Under those conditions, the hydrophobic valines find their way into hydrophobic pockets of other hemoglobin molecules and form polymers. Fortunately, these polymers dissolve the moment they are re-exposed to oxygen. Now let's look at what happens in cells. Below we see oxygenated cells from a person with sickle cell anemia. As shown above, all the hemoglobin is oxygenated and in solution. When oxygen is given up, the hemoglobin assumes the deoxyconformation, but the cells are barely affected. However, if the cell becomes stuck in an adverse environment, the deoxysickle hemoglobin will begin to polymerize, and the cells will become less deformable and can even distort into the sickle shape. Upon return to the lungs, the polymer melts and the cells regain their flexibility. Note that some cells are sickle-shaped regardless of whether they have polymer in them or not. These are called irreversibly sickle cells and are the signature cells found on the peripheral smear of patients with sickle cell anemia. Most of the time, in most of the circulation, cells give up oxygen and move through small vessels so fast that they don't have time to sickle in place and obstruct flow. Even if they do lose flexibility and distort, by then they are usually in large veins and are carried back to the lungs to buff up and recirculate. Even without any vascular obstruction, though, the repetitive oxy-deoxy sickle-unsickle cycles take a toll on the red cell membrane. This is a smear from a patient with homozygous sickle cell anemia, graphic evidence of the membrane damage. What you see are irreversibly sickle cells that don't have polymer in them but are misshapen, some normal-looking cells, some targets, and some big bluish cells that are probably reticulocytes. If you looked for more subtle evidence of membrane abnormalities, you'd find a lot. These damaged cells have a 15 to 20 day lifespan, a fairly brisk chronic hemolytic anemia that is not linked to symptomatic episodes of vasoocclusion. Vasoocclusion and organ damage from sickling is most likely in certain unfavorable scenarios. In organs with inherently slow, boggy circulations like the spleen, marrow, and venous sinusoids of the corpus cavernosa, cells come in fully oxygenated but hang around deoxygenated for long enough to lose their flexibility, deform, and cause distal ischemia or necrosis, splenic sequestration, painful bone crises, or priapism. Another problem is that the red cell itself, because of its abnormal membrane properties, can adhere to endothelial cells, activate them, neutrophils, and platelets, eventually setting up a whole cascade of events that can cause a proliferative vasculopathy, slow transit time, and more vasoocclusion. So another vulnerable scenario for vasoocclusion is in organs that have developed severe proliferative vasculopathy, the most common being in the large cerebral arteries. This causes stroke. Vascular beds with mild vasculopathy are particularly vulnerable when the patient is hypoxic, as in the acute chest syndrome. Under these situations, cells arrive already deoxygenated on the arterial side and can cause distal ischemia. Patients experiencing acute chest syndrome are extremely vulnerable to stroke, pain, and other potentially fatal complications.